problem
is going to.
So good evening and a warm welcome to all the dignitaries present here. Myself Rupsha from ClearNet, assigned as the session assistant to ensure a seamless experience. ClearNet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that ClearNet is the digital partner of this event organized by Cancer Kids Strength of Smiles Doctors Network Maharashtra. And the topic of today's session is Ekatrasetu Webinar Series, coming together for better survival of childhood cancer. So let's begin today's session, for which I would like to introduce Dr. Pankaj Dwivedi, sir. Just allow me a moment to share sir's CV. So I believe my screen is visible to all. So sir is a senior consultant at Pediatric Oncology in National Cancer Institute, Nagpur, and he will be moderating today's session. So sir, please over to you and proceed with the talk. Thank you. Sir, kindly unmute.
Can you share introduction slides for other speaker?
I'm sharing.
So till the slides are uploading. So welcome everyone. This is our web series. So every month or in a so days, we try to discuss pediatric oncology cases. This time we thought that everyone is getting a little bit confusion, little bit actually blurring of our guidelines is there. So we thought that why not to discuss the rare tumors. And then when I and Dr. Monica with other friends we discussed, so then we decided to start a series on our rare tumors so that we can share each other's actually experience we in this web series and experts' opinion as well. So today, with me, Dr. Maya Prasad is there, who's going to be the one of the expert for us. She is a professor pediatric oncology at Tata Memorial Hospital, Mumbai. Another one, Dr. Amos Loh. He's a senior consultant pediatric surgery at KK Women's Children's Hospital, Singapore. Can you share Sajid sir slide? Yeah. So we have Dr. Sajid Qureshi. He's a professor pediatric oncosurgery. He is the teacher for all of us. So if you have any query that is not solved by you, then you can discuss to sir as well. So he's the professor pediatric surgical oncology at Tata Memorial Hospital, Mumbai. So I welcome all my experts and the panelists. Before we start this thing, I would like to actually give you the flow of the today's activity, how we are going to actually organize this activity. So first is the overview of the rare tumors, how you define, what are the definitions for rare tumor, which are actually a rare tumor or a very rare tumors. So this will be overview given by Dr. Maya Prasad. And then overview on ACC, that is, we have chosen 3 tumors today to discuss. Actually, one is a adenocortical carcinoma, another one is a thyroid cancers, and third one is the inflammatory myofibromatosis. So if the ACC tumor, there is a actually overview will be given by Dr. Amos, and then we will have a case presentation by Dr. Tripti, and then we will have a ACC panel discussion. After that, the thyroid cancer overview will be given by Professor Sajid, and then Dr. Monica will conduct the panel discussion on thyroid cancer. And there is also, we have a case, so that will be presented by Dr. Akriti. She's a special SR at Pediatric Surgery Unit in TMH. And then after that, Dr. Amos Loh, and then after that, we will actually discuss the IMFT, where we also have the case presentation and the panel discussion. I would like to start with the Professor Maya, and I would invite him to give an overview regarding the rare tumors in pediatric age group. So over to Dr. Maya.
Good evening, everyone. Hello. Pankaj, is the volume okay, and can you see the slides?
Yes, ma'am. The
It is okay.
PPT is perfectly visible and your voice is also fine.
Okay.
Yeah.
So thanks, Pankaj, and thanks, Monica. I think this is, I mean, it's great that you decided to include this topic in your series of webinars. And I'll just give a very, very brief overview of what are rare pediatric tumors and why it's important to have this classification. So I think anyone who deals with pediatric cancer knows that pediatric cancer itself is a relatively rare condition because less than 5% of all cancers across all age groups occur in children. But even within this group, there are certain subtypes. There are certain cancers within pediatric cancers which are even rarer, and these are known as rare or infrequent pediatric tumors. So infrequent is the term that's used by COG. So here we see that this is the proportion of cancers which is classified as rare pediatric tumors within the COG. So it constitutes around, depending on which group has done the classification, it may constitute around 8 to 10% of all pediatric malignancies. And although this may not seem like a very small number, you must remember that there are many, many tumor types which are contained within this classification of rare tumors. So COG actually defines rare pediatric cancers by their histology. So which is probably one of the easiest ways to do it because you already know which are the tumor types which are very rare, and those are the ones which are considered to be rare. Whereas the European groups look at it by the incidence. So for somebody like us who are in India, we don't know the exact incidence of each cancer that occurs in our population. So having an incidence-based classification may not be very easy for us. So it's probably best to see which are the histologies which would constitute the rare tumor types. So why do we need to even bother about making a separate, collection of tumors like this, which are known as rare tumors? Mainly because they are small in number. And if you go by the histological classifications, there are several tumor types which are included within this. And even within the tumor types, they may arise from various organs. I think when we go through the cases today, it will be very, very apparent that, there's so much heterogeneity, and to know the details of each of these tumor types is quite difficult. And because they're so small, we do not actually have complete understanding. It's not like any other tumor types, for example, like lung cancer, where, so much of study has been done because of the number of patients who are there. And because of the low numbers, again, it's nearly impossible to have randomized controlled trials. And most trials are either single-arm prospective trials, or most reports are just, case series or retrospective studies. Also, because the information available is not, that solid, it's been difficult to make guidelines. But as we will see later, there are a few groups which have been making guidelines. And unfortunately, although we know that pediatric cancer is the success story of oncology, these rare tumors somehow have not benefited as much from all these advances. And lastly, the vast majority of these rare tumors occur in patients who are 15 to 19 years old. So they are usually adolescents, and they are in that age group where, neither the pediatric oncologists know how to take care of them, or nor do adults really know to. Adult oncologists really know to take care of them. So all this makes it a difficult category. So which are the common rare tumors? They are overall, this is by alphabetical order. So the common ones are adrenocortical carcinoma, although it's only 1%, colon cancer, melanoma. This is the COG percentages. So that's why it's so high. Desmoid tumors, gastrointestinal stromal tumors, extrarenal rhabdoid tumors, nasopharyngeal carcinoma, neuroendocrine tumors, nut midline carcinoma, which is incredibly rare, pancreatic tumors, pleuropulmonary blastoma, sex cord stromal tumors. So this is a classification of COG, which may not exactly be the classification of any other group. And thyroid tumors, which are actually one of the most common subgroups amongst these. So let's look at what is there a difference in the epidemiology within Western countries and India. The data from India is from a multicentric prospective study, which has been conducted over the past 5 years. And that's how we got these numbers of close to 400 patients. So in COG, melanoma is 30%. In our Indian group, it's only 3%. Thyroid cancers are 37% of the rare tumors in COG, whereas they're only 14% within the Indian population. Another very glaring difference is the nasopharyngeal carcinoma, which is only 3% in COG and 15% in India. So it's, as you can see, they're quite different within different ethnic and race groups, may be related to the socioeconomic status as well. For example, we know that nasopharyngeal carcinoma is related to EBV. So there could be a multitude of factors, but until we study all these in great detail, we are not going to be able to know why these numbers are so different. So how do we improve outcomes? There have been several initiatives which have been looking at this, because all these problems have been realized earlier on. So there are, across countries, there have been registries, and there are studies which biobank tumor tissue. But because these tumors are so rare, it requires a lot of motivation and continued effort to keep doing this year after year. The COG has got something called the COG Every Child project, and the European expert group has combined several the rare tumor study groups from several countries, and they have been doing single-arm clinical trials, and they have also been working with adult cooperative groups in order to increase the numbers and also to learn from the experience of adult cooperative tumor groups. Also, the expert has had a very successful virtual tumor board, whereby people from smaller centers have been able to learn from the larger expert group of rare tumors. So these are all the tumor guidelines which are now being available. You can see that they are actually only from 1 or 2 groups. And anyone who's interested in this, please look up. There are 2 special issues. One was in European Journal of Cancer Pediatric Oncology, and one in PBC. Both are freely available online. So they have a lot of these guidelines are all available free, full access. So this is just an example to show how collaboration can be done successfully in rare tumors. And this is the example of the expert group, which is a European group, where they have been doing multiple things. So they've been doing biobanking and registries. They have been having virtual tumor boards. They've been having, they've been making guidelines, and they are doing single-arm studies as well. So I think that's it from me for now. And over to you, Pankaj.
So, thanks, Maya, for such a brief introduction about the rare tumors. Actually, you are right that something which may be rare in Europe may not be rare in Indian setting. For example, CNSopharynx, we see a lot of CNSopharynx as compared to COGO trial or whatever the European they say. It is also worthwhile to seeing the resources where we can get the help or the guidelines for treating or management of the rare tumor. So I wish, thank you, Maya, for this overview. And now I would like to move on for this ACC, adrenocortical carcinoma. So here I would like to actually invite Dr. Amos Loh for giving the overview of ACC. And then this will be followed by the case presentation by Dr. Tripti. So Dr. Amos, can you listen me?
Yes, hi, good evening, everyone. Yeah, so I actually was gonna also share broadly on other adrenal tumors, non-neuroblastoma. Maybe I would just go into a short presentation on that first.
Sure.
Great. So let's have this, right. So thanks. I know we've got a case presentation on adrenocortical tumor. I'm gonna just take a couple of minutes with us and try to treat this broadly. When we talk about non-neuroblastoma tumors in the adrenal, sometimes it's a bit like this when we in pediatric cancers think about the adrenal tumors. First and foremost, we think about neuroblastoma. The next 2 we think about are pheochromocytoma and adrenocortical tumors. Then there's a long tail of others that most of us don't recall. But I'm going to focus just with a couple of minutes to talk first about pheochromocytoma, and then we'll talk about adrenocortical tumors, just so that we've got complete coverage of the topic. So just to mention on pheochromocytomas, these are known as a group called PPGLs, along with the paragangliomas. Catecholamine secreting tumors and the 10% tumors that we remember from medical school. Most of the figures there are largely inaccurate, but it's easy for medical students to remember. In children, we know that about 3/4 are pheochromocytomas and 25% paragangliomas. What's important to know is that we look for paroxysmal symptoms and also a very strong hereditary feature, something we'll learn about in the adrenocortical tumors as well later on. When we think about pheochromocytoma, the important thing that we first go to is biochemical testing. But soon after that, functional imaging needs to come into play. And this is where radionuclide scans are required, largely MIBG and DOPA or DOTA-Tate scans. And it's important for us in the surgical field to also be thinking about malignant potential. And we know that tumor size is directly related to malignant potential in this group of tumors. I want to point us to a set of well-established management guidelines here that really is the gold standard for the care and management of PPGLs. Key points I'll just bring to us: initial biochemical testing in urinary metanephrines, that's important. Imaging is important from the anatomical standpoint, but MIBG is critical to understand and look for metastatic disease. Genetic testing recommended in all patients, and I'll show us an example in a short while. When we think about perioperative preparation, this again is something where we need the endocrinologist on board for alpha, then beta blockade, and then care of fluids. And in the surgical approach, less is better in this case with MIS adrenalectomy. I think it's relevant to talk about this because as we look at adrenocortical tumors later, it's going to be the direct opposite. Lifelong follow-up in this case because many of these children are genetically predisposed, right? And so really in terms of perioperative, we want to get alpha blockade on board first before we block with beta blockers, right? And this should be the standard for care of pheochromocytomas. In many adult centers and large volume centers, you may proceed with alpha blockade only if there is enough perioperative anesthetic support. I think it's important to remember resection margins and histology and genetics are key prognostic factors that play into the outcomes of these patients. Okay, I am going to jump us forward. Give me a second. And talk to us about adrenocortical tumors now, right? So this is another group, and we're going to focus our attention on this tonight. Higher incidence in adults versus children, but some of these epidemiological divisions can be a bit artificial depending on where this branches off. I'm going to show you a case later to illustrate this. Key issues we need to think about threefold. One, the clinical aspects, largely centering around endocrinopathies. Second, being that of imaging and detection, both of the local site as well as the distant site. And then finally, thinking about hereditary symptoms, right? So when we come into the approach to a workup for adrenocortical tumor, again, the biochemistry should be our first line, followed by anatomical imaging, and then moving forwards from there. It's important to think about that in adrenocortical tumors, that surgery really should be complete and open. I'll talk about the recommendation here first, because this is necessary for us to yield a tumor with as little risk of rupture and spillage as possible. Thereafter, when we think about histology, we're going to look at the malignancy potential, and I'll talk about the criteria subsequently. Before then, we look at staging and systemic treatment. It's important to point out in adrenocortical tumors that there's often a strong genetic association. TP53 gene mutations in Lee-Fraumeni syndrome are associated in more than 50% of children And so this is really the key thing. And we want to go back into the family history and also think about the effects of this on the child. Your use of radiation, given their P53 mutational status, as well as the predisposition for other cancers later in life. A host of other syndromic conditions, such as Beckwith-Wiedemann and MEN1, are also associated with adrenal cortical tumors. So it's fairly frequent if we know how to look for it. I want to pause a minute here and talk about the Wernicke's criteria for malignancy. This is a determination of malignant potential, and this is important to point out because adrenal cortical tumors are not black and white as in benign and malignant, but there is a gradation in between. And this is something important for us, I think, from physician standpoint, as well as in communication to patients, to help them understand that there isn't a clear division between benign and malignant, and that there can be varying degrees of malignant potential. We talked about endocrinopathies and how in surgical management, radical resection is the gold standard. In the COG-ARAR guidelines for adrenal cortical tumors from the 90s and the 2000s, it did recommend even that in this diagnosis, it is warranted to remove adjacent normal organs if this was required for a complete resection of the tumor so as to avoid spillage. And this was the COG guideline and remains the guideline till today. And I think it's warranted for us to bear in mind because often an excessive radical approach can be criticized, but this is one situation where that may well be necessary because the systemic therapy to salvage a situation is fairly limited. I'd like to take a couple of minutes of our time to share with you a case that we had before we hear your case as well. And this is a story of a case we had, which came from another surgeon that performed the right adrenalectomy for a patient with an adrenal cortical tumor and had local rupture of the case. The tumor markers normalized postoperatively and everything seemed well. And the child refused adjuvant chemotherapy because of their social beliefs at that time. But unfortunately, a year later, the lesion reoccurred. And if you can look in the CT scan, in the MRI we performed here, you can see a fresh lesion on the posterolateral aspect related to the right kidney in this case. Now, this presents itself with a situation where this is not a discrete tumor. This would be adherent to all the surrounding structures, and the surgical approach in this case would be to resect this with a rim of normal liver and kidney and chest wall adjacent to it. That was performed, and the patient then did agree and went on to AR-0332 chemotherapy thereafter. This is an image of the resection that was done with a section of the right lobe of the liver and part of the kidney. And as you can see in this case, the tumor has no capsule. It is adherent to all the surrounding tissues, and this is really the only way to try and salvage a local recurrent tumor that has been spilled. Following this relapse, unfortunately, 4 more years later, the patient had a second recurrence, this time up in the paraspinal region. Fairly tricky area here, and that was followed, and this continued for a while. And was monitored over the course of about 12 to 18 months and was noted to be gradually increasing. This was a large undertaking, and I'd share with you basically what our attempted surgery was, because this required a resection of what was a very central portion of the liver and part of the vena cava in order to gain local control. Again, remembering that there's no true capsule to these tumors, and that really a capsule is artificially formed by resecting the adjacent tissue around it. This involved the posterior sectionectomy, as well as en bloc resection of the diaphragm and chest wall, as well as segmental cable resection with vascular reconstruction. And these are views that we see peering into that hole. The timestamp tells you that the surgery went on into the night with the vascular reconstruction. And then here you have the specimen removed with the lesion trapped inside it, right? And the patient had remained disease-free since then. Just in 2 more closing slides, I want to show with you some other rare birds, and other things can find their way into the the adrenal gland. And let's not forget that, because we can often find strange diagnoses. This is a case of a pulmonary sequestration diagnosed as an adrenal lesion. We did this patient with a retroperitoneoscopic approach, with a three-port approach to remove that. So I would say the positive note was that this was minimally invasive and did not enter into either the chest or the peritoneal cavity. Another case with a rare diagnosis, this is a vascular tumor, angiomatoid cystic fibrous histiocytoma. Again, approach with a retroperitoneoscopic approach from the back. This case was presented with pyrexia of unknown origin and was undiagnosed until a PET scan revealed a hot spot in the left adrenal location. And you can see in the charts here, after the retroperitoneoscopic removal, immediate resolution of the fever and the corresponding parameters as well. And in the image below, you can see the lesion removed by retroperitoneoscopy, right? So that's what I have to share. Would you like to proceed on, Dr. Pankaj?
Yeah, thanks, Dr. Amos. It's a nice presentation actually, and I think with this background, there are a lot of things to learn with this presentation, and we have also come across these rare tumors. So one of the from my institute, Dr. Tripti is going to discuss that patient, and another patient sometime we can discuss who has a recurrent relapse recurrent adrenocortical carcinoma, and every time he has been operated, put on a metoten and all. Right now he is okay, fine, after repeated surgery. So this particular case is a first case we come across. So I would like to call Dr. Tripti to present this case, and I can share my screen as well, so everyone can see that case. Dr. Tripti, are you there?
Yes, sir. I'm here. Can you share, sir? From
Yes,
your
yes.
side?
I will share this. Can you see the presentation?
Yes, sir, it is visible.
Visible?
Yes, sir, perfectly visible.
Okay, so over to Dr. Tripti. She is the associate consultant at National Cancer Institute, Nagpur, and now she is going to present first case for today, that is adrenocortical carcinoma. Over to Dr. Tripti.
Thank you, sir. Thank you, everyone, for giving me the opportunity. I would like to start with the case. Am I audible?
Yes, ma'am.
Okay, okay. So, will you change the slide? I'm not able to do it from my side. Okay, the first one. Okay, so we'll start with the case. So we had a child which was 5-year-old female child. She presented to us with the complaints of abdominal distension, abdominal mass, and rapid increase in weight gain. With the thought of on adrenal mass, we evaluated her endocrinologically and found that her DHEA was raised at presentation, which was more than 1,000. Then she underwent a CECT abdomen. So next slide. On imaging, it was show. I don't have the images right now, but I had the description, in which it was showing a solid mass in the right suprarenal location, which was around 8 into 6 into 9 centimeter, of which the right adrenal gland cannot be seen separately. Superiorly, the mass was infiltrating the right lobe of liver. Anterosuperiorly, it was ended in the gallbladder and also averting the second part of duodenum. It was involving the IVC proximal segment of right renal vein, and it also had a tumor thrombus. There was a multiple reactive mesenteric lymph node, the largest measuring were 1 into 0.9 centimeter. In metastatic workup, her bilateral lung parenchyma were normal. So next slide. With this, she underwent a right suprarenal mass excision at TMH Mumbai. Her histopathological report is attached here, in which it was on microscopic description. It was showing that there are multiple segments, which is showing a capsulated malignant tumor. It is composed of epithelial morphology. It also had a mitosis in 12 to 15 out of 10 HPF. There was atypical forms. Capsular invasion was not there, but as vascular invasion was there, and there were a scanty normal adrenal glands seen. There was an area of necrosis and calcification. So with this, she was again referred back to our center, on which we performed the PET scan of whole body for metastatic workup, and it was a non-metastatic disease. So then, to summarize, so next slide. So this is a 5-year-old female child operated case of right suprarenal mass, HPR proven adenocortical carcinoma, FDG non-metastatic, non-residual disease. As per MOD-WIS criteria, she was having a mitotic rate more than 5 in 15 cells, abnormal mitosis, necrosis. If we calculate the score, it was 4, and it suggests that if scores are more than 3, it is a malignancy. So we had a final diagnosis of adenocortical carcinoma with MOD-WIS score of 4, MIB index 15%, and stage 2 disease. So with this background, we started the child on mito-10 in view of large tumor volume and disease of stage 2. Her endocrine work evaluation was done, and according to that started on the replacement therapy. With the mito-10, she was kept on regular follow-up. So on follow-up, she with the disease-free interval of around 17 months, she developed a solitary lung nodule in the lower lobe of the right lung. At the time of relapse, her serum DHEA was normal. So, with this solitary nodule, she underwent metastectomy, and after this, we started the child on the systemic chemotherapy as per the EDP protocol, which contained the cisplatin, etoposide, adriamycin. So, we give 6 cycles of cisplatin, etoposide, adriamycin along with mito-10. After completing the systemic chemotherapy, her mito-10 were continued for 2 years. So on further follow-up, the recent PET scan which was done on January 2024, which is showing a CMR, and she is regularly in follow-up with us, also along with the endocrinologist, and we are doing all necessary workup which is required. Right now she is doing well, going to school, everything is, till now everything is going well. So over to you, sir. We'll have the discussion, panel discussion.
So thank you, Tripti, for this brief descriptions of the case. So we can start actually the case discussion. If just a minute, I'm sharing my slide again. I don't know why it is not. Can you see the slides?
Yes, yes. You have a question here about differentials, yes. What we should be thinking about.
Yes, yes. So it is actually a very common, most of the time, the patient presented to the general pediatrician rather than to us or a pediatric surgeon, and later on they refer to us. So as a common question, child with adenomas, what differential should be in our mind, though you have presented in your presentation as well. So Dr. Amos.
Yeah. So I think just to refresh on that, the broad concept here is indeed right. Often these patients would come with fairly florid signs, and especially when there's an endocrinopathy that accompanies the presentation, then it narrows us really down to these two other diagnoses that we talked about, right? One which is predominantly catecholamine driven, which are the PPGLs, and in this case, the ones which are largely steroid hormone related, which then are the virilizing tumors. So, you know, in this case, really nicely done with the biochemistry up front, demonstrating the raised DHEA. And then we arrive actually very quickly at the diagnosis. And I thought that going on from here, the imaging was particularly helpful as well in terms of deciding not just the ascertain, confirming that we've got an adrenal tumor, but also it's a setup for the surgery subsequently, because the imaging would tell us what are going to be the structures at risk.
So yes, so as you also shown in your this previous slide. So we have this few differential diagnosis for adrenal masses like neuroblastoma, ganglioneuroma, or adrenal cortex tumor, or a pheochromocytoma, or adrenal cyst, or adrenal hematoma. So for this case, this was the presentation, and we got a DHA high, and we did the imaging, and that's found to be the adrenal mass. So the another question for Professor Sajid sir, how to approach adrenal mass, what investigation, imaging, and biochemical parameter we should consider, and how you will decide the biopsy versus excision of the mass.
Thank you, Pankaj. For adrenal masses, the commonest tumor in the adrenal region, we know it's the neuroblastoma. But when you have special situation like this, wherein the clinical radiological picture is suggestive of adrenocortical tumor or non-neuroblastic tumor, I would say, then the investigation should be directed towards that. And once you have narrowed down with all the list of investigation, what Amos has just listed about, and you have certainly decided that this is an ACC or a non-neuroblastic adrenal tumor, then a call about a biopsy or an excision has to be taken. Now, if it is a well-circumscribed mass, the relation of the mass with the adjacent structure, the lymph nodes, and that's a surgeon's feel that it can be excised or not. If it is that, and a safe surgery is possible, definitely excision biopsy, in the sense, do a complete removal of the mass is preferred over a biopsy. Having said that, if there is a slightest concern that there might be a clinical suspicion that we are dealing with some other tumor like a neuroblastoma, you should not hesitate from doing a biopsy. But a call about the biopsy or an excision biopsy has to be taken on case-by-case basis. And the investigation, especially the biochemical workup, which is so important in clinching the diagnosis. We know if it is a viralizing tumors, the diagnosis is very certain, but in absence of viralization, the biochemical parameters really help.
So very helpful to decide on OPD basis actually where to send the patient for considering a biopsy or excision of the mass. So the another very important point actually, which actually Dr. Amos has highlighted, invasive versus laparotomy, minimum invasive versus laparotomy. It is clear that obviously if you are dealing with the ACC, the laparotomy and excision is should be the norm. But in which cases you would like to go for a minimum invasive versus the laparotomy, Dr. Amos?
Yeah, I think that's a good question. I think it's important for us to approach this broadly, because if we get lost in a single diagnosis, I think we can it may be a pitfall and can cause individuals to choose wrongly. I agree with you. In the context of an adrenocortical tumor, it's an open surgery and it's a radical resection always. There is no place to attempt anything minimally invasive in an adrenocortical tumor. I think it's important to point out that these tumors have basically a very soft consistency and hardly any capsule. It's important to remember that, because they are extremely easy to rupture. In fact, in some literature and guidance, it's more recommended that thoracoabdominal incision be undertaken if there is a large adrenocortical tumor, particularly one that involves the diaphragm. The rationale being that these large approaches will help to minimize the risk of spillage. I would only really attempt a laparoscopic or a retroperitoneoscopic resection in a diagnosis other than this. I think in pheochromocytoma or in a neuroblastoma without image-defined risk factors, I think in both of these indications, perhaps there can be a role for MIS, but otherwise, I think we must, in all other cases, with IDRFs in neuroblastoma and in adrenocortical tumors, err on the side of open surgery.
So thank you, Dr. Amos. So these are what we have discussed so far. So your surgical approach or a non-surgical approach depend on what are the tumor markers is there, whether your DHA or other parameters has raised, what is the histopathology if the biopsy initially has been done for for example, of neuroblastoma or something, volume of the tumor and IDRF, and now you have cleared where the minimal invasive or a laparotomy is indicated. So we know that the ACC are having the very low incidence. They're the 0.2% of the pediatric tumors. They have a bimodal distribution and presented during the first 5 years of the life. And the female to male, female is more common than in the male. And then germline TP53 variants are the predisposing factor for ACC. And back with Wiedemann, as you already mentioned, and hemihypertrophy syndrome, they also have a higher chance of developing the ACC. So what are the clinical symptoms in the children with the ACC? Dr. Maya, you come across in OPDs?
Yeah, Pankaj, thank you. Thanks a lot. So I think most of the children with ACC are clinical spotters, and the younger the child, the more chance of there being a very clinical, very obvious, overt clinical presentation. And as your slide shows, most children have got secreting tumors, and generally it's a combination of both virilization and Cushing's syndrome. So Cushingoid features, they all come with Cushingoid features, and a lot. Large proportion come with virilization. And if at all they are non-secreting tumors, it's usually in older children. So I think the other thing that we get is hypertension. So that may be one of the first presenting features that may actually point to this, and something else which is very important if we are planning surgery. The other thing that we might need to look for is that because a large proportion of them actually may have Lee-Fraumeni syndrome, we should also look for features of Cafe spots or other cutaneous markers which may rarely be present in Lee-Fraumeni.
Yes. So sometimes the signs are obvious. We know that virilization happening, something is going wrong, and with the CT showing a adrenal mass, we come to the conclusion that okay, we are dealing with this thing. But this message I want to actually send across, because my pediatrician friends are also seeing. So sometimes the patient come with the after biopsy, adrenal tumor with the biopsy, and they know there the virilization clinical symptom are suggestive of we might be dealing with the ACC. So I know it's a very important thing to distinguish whether we are dealing with a benign adrenal tumor or it's a malignant adrenal tumors. So Dr. Amos, can you help in deciding that what scoring system you use at your center to define the malignant potentials of the adrenal tumors?
Yeah, so I think in this case, again, as what we shared earlier, really we're looking beyond just histopathology in this case. I think it's important for us to come away with the concept here that histopathological evaluation of these adrenocortical tumors are not necessarily the entire picture of whether we're dealing with something with a higher or lower malignant potential. And using the Wernicke score, which is what we use, it still isn't 100% as what you show in the chart here. It's not 100% accurate to distinguish something that is benign or malignant. Therefore, I think that's an important message to get across to parents, especially because many of them would want to know, is my child's cancer something that is benign or something that is malignant? Doctor, tell me, is it one or the other? And helping them to understand that can be challenging. I think the other aspect of this is for us not to be over-reliant on a histopathological diagnosis to decide our subsequent management. That even if it does show a moderate malignancy risk, as you showed in the case illustration earlier, it's important to maintain vigilant observation of this patient and follow them up, because latent relapses can occur. I showed you in our case how up to 4 years later, a local relapse can still occur as well.
Yes. So yeah. So it is right that must have we must follow them very closely. Though we have these scoring system like Vance Rutan or a V's or a modified V's or a Winkes. So most of the time the Wankies had a more sensitivity, though specificity is low in all these three scoring system. Still, we can use to define whether the lesion is a more of a malignant or of a benign. So with this, this Wankies criteria is like a tumor weight more than 400 gram, tumor size more than 10.5 centimeter, and extension into the periadrenal soft tissue and or adjacent organs, invasion into the vena cava, venous invasion, capsular invasion, presence of the tumor necrosis. We can ask our pathology friend to give the report in these headings as well, like a mitotic index of more than 15 out of 20 high power field, and the presence of atypical figures. Presence of up to 2 of these criteria support a benign evaluation, 3 open evaluation, and the 4 or more is the ACC. So this is give you a little bit of guide, but definitely a common sense. Another feature also you have to see to define the nature of the adrenal lesions. So what are the genomic alteration common in pediatric ACC? Because now all the things are going molecular. So Dr. Maya, can you help us to which actually genes and what are the somatic or germline mutation we have to consider? They are more associated with the ACC.
So, as your earlier slide showed, around between 50 and 95% of children with ACC could have Lee-Fraumeni syndrome. That actually depends on the population where they are from. Most of the studies are from Brazil, and there is a founder mutation. So that's why the incidence of Lee-Fraumeni is so high. And the incidence of having an underlying cancer predisposition, Lee-Fraumeni, is higher if the child is younger. So that is definitely something that we need to look for in all children. We need to look for a familial predisposition syndrome. The other syndromic association is with, although it's not familial, it is a cancer predisposition syndrome, and that is Beckwith-Wiedemann syndrome. So these are the two genetic things as far as cancer predisposition syndromes go. And when we are looking for somatic alterations, IGF-2 expression, again, as you have shown in your slide, is the most common one. So in the series of, again, it was, I think, mostly from Brazil, which they found that around 90% of children had IGF-2 overexpression. So we spoke about Lee-Fraumeni syndrome, but TP53 can also be a somatic mutation. So it's not just germline. It may also be present as a somatic mutation in some patients. And ATRX and beta-catenin variants also may be present as somatic variations. So definitely, I'm not sure how much these somatic mutations have much of a prognostic value, but definitely TP53, either germline or somatic, would have an implication on the treatment and prognosis of this child.
Yeah, so regarding TP53, somatic TP53 has a poor prognosis. And the other thing is that, as Dr. Amos also highlighted, while using a radiotherapy in these patients, actually they are a little bit of radio-resistant tumor, but even then there is some adult data is there of using a radiation in these patients, but then they make more of prone for a secondary malignancy, the presence of a TP53 germline, and somatic TP53, they are having a poor prognosis as compared to non-TP53 mutated ACCs. So then how to prognosticate the ACC, Dr. Maya?
Yeah, I think there are a lot of prognostic factors which have been given in literature, but for us, thanks for putting this slide, it makes it much easier for me. But I think from our scenario, I think we come across a lot of children who come with metastatic disease. They do extremely poorly, especially if the metastasis is kind of large and unresectable. So none of them actually make it if there is a large metastatic disease, especially if it is unresectable. Large tumor sizes, which again is something that we come across, are poor prognostic factors. And what we have noticed is incomplete, rather than incomplete resection, if there is a spillage during surgery. I think Dr. Sajid and Amos, both of them mentioned how friable it is. And if there's a rupture and spillage into the abdomen, it makes it really very difficult to treat, especially because they are radio-resistant tumors. And I think the rest of it is all here for everyone to see. You already mentioned that somatic TP53 variants are poor. Actually, even germline are not good because they tend to have second malignant tumors. So, I mean, that itself will decrease the outcome of the patient person.
So, Sajid sir, can you highlight the what special things you keep in mind while you are planning the surgery for the ACC?
So adrenocortical carcinomas as compared to other adrenal tumors are different in the sense Amos has also highlighted that it's very easy to rupture them. You can just imagine this tumors like a dough, and it's very, very easy to rupture them. A single finger pressure also may rupture the tumor. And in addition to having a prognostic implication, you will have problems at the time of surgery. It's very difficult to stop a bleeding from a ruptured tumor, and you have to be really quick enough to get the tumor out, taking all the due precautions. So while planning the approach, my preferred approach and everyone's preferred approach is an open approach, and we go for a laparotomy. Depending on the size of the tumor, we take it either transperitoneal, transabdominal, or we go the thoracoabdominal way. Whichever way one is comfortable, that approach can be utilized. And special care has to be maintained while mobilizing the tumor, because these are very friable tumor. The idea of going for the vessels first, ligating them and all those things is good in theory, but practically it's most of the time not possible. So you should go for the best possible way, which is meticulous dissection. And you have to remember that it's not only the vein, there are arteries also to deal with, and in large tumors these artery could be of good size also. The other thing which has to be taken into consideration is presence or absence of lymph nodal disease. If you're planning for a surgery, go for a complete excision. There's no point in addressing the primary and leaving the enlarged nodes there. It has to be a complete excision. The role of sentinel node biopsy in absence of lymph node, clinically apparent or radiologically apparent node, is not known, but it is better that whenever you are in that area to address the at least do an inspection of that site, and if nodes are there have to be tackled. One more important concern is, and we have seen that quite often, adrenal tumor also, adrenocortical carcinomas also have a tendency for venous invasion, and we have seen thrombus extending into the renal vein, especially on the left side, and into the IVC, and we have encountered tumors with thrombus extending into the atrium also. So as we don't have a cover of chemotherapy, most of them will undergo an upfront surgery, though we have tried chemotherapy also in these patients with very negligible success, like the thrombus remained the same, and even the friability of the thrombus remained the same as compared to a thrombus of the Wilms tumor after chemotherapy. So whenever you go for that, good preparation, and if required, a cardiac support. If the tumor thrombus is extending into the atrium, a cardiac support is required. Apart from that, if it is a retrohepatic or even a suprahepatic infracardiac thrombus, it can be resected without a cardiopulmonary bypass. But you have to remember, these are different tumors. The thrombuses are different as compared to neuroblastoma or a Wilms tumor thrombus. So due exercise in mobilization, due care should be exercised in mobilization and resection of these tumors.
Yeah, so this is the management from the COG group, that we know that the surgical excision is the most important part of managing ACCs. So for a stage 1 tumor, there is one trial. This was the trial from the COG group where stage 1 disease complete excision was done. This is a limited disease without any node involvement. Stage 2 disease, tumor larger than 200 ml or heavier than 100 gram, treated with adrenalectomy and RPLND. Stage 3 disease, incompletely resected primary tumors, and stage 4 disease, distant metastasis disease is there. So for stage 3 and stage 4, treated with surgery of the primary tumor, RPLND, and they have given the cisplatin, etoposide, doxorubicin, and mitotin. So just see what are the outcomes and what are actually, which is not, there is a paradox that stage 1 disease, the outcome is 86.2%, 5-year EFS estimated. But for a stage 2, it is only 53.3%. But for a stage 3 it is a 81%, and definitely for a metastatic disease only a 7.1%. So they have given, when they analyze their data, they have given that inferior results of stage 2 because of the inadequate RPLND. So this was from them, the answer. So now I would like to ask Dr. Maya the very important question, and what we come across, the role of chemotherapy and mitotin, and how to titrate the dose of mitotin. We know we don't have the level. So one way is, I can think that the side effect, once you have the side effect, you should actually modify the dose. But Dr. Maya, can you help us to tell us what is the role of a chemotherapy and mitotin?
So, Pankaj, I think you very well explained about how the only single prospective trial in adrenocortical carcinoma, the COG trial RAR 332, actually gave chemotherapy only in stage 3 and stage 4. I think it's commonly accepted across all groups that children with stage 3 and 4 ECC need chemotherapy. But as we saw in stage 2, the outcomes was quite inferior. It was really even worse than stage 3. So probably there is a role for either giving fewer cycles of the same chemotherapy or giving mitotin alone. But I don't think there are yet any recommendations or a consensus on whether chemotherapy or mitotin is required in stage 2 ACC. And again, I think we all know that the most commonly used regime of drugs is CED, which is cisplatin, etoposide, and doxorubicin. And maybe between 6 to 8 cycles would be recommended in stage 3 and 4. And again, we saw in the previous slide that stage 4 really does not do well, even with all this treatment. So let's come to the more important question of mitotin. I think this, at least for 10 years, I remember having, discussed mitotin back and forth, especially because it's very expensive. It's still not available routinely in India, and we have to get it through, either other sources or through a gray market. It's still very expensive. So even a bottle costs around 50,000 rupees, and it has to be given daily and probably for around 2 to 3 years. So as Pankaj mentioned, it's very toxic. It has a very narrow therapeutic index, and because it works by destroying the adrenal cortex, it needs to be monitored really well. So it causes all the hormones to crash. So an endocrinologist needs to be completely on board as soon as we start mitotin, because within a few weeks, the hormone levels start to crash, and they need to be on glucocorticoid and mineralocorticoid supplementation. The other, the really troublesome side effects are GI side effects and neurotoxicity. And because the therapeutic index is so narrow, it has to be maintained between 14 and 20 nanomoles per ml, I think. And below 14, actually, it does not achieve much efficacy. There have been studies which have shown very different survival curves in children who have received, it's not in children, in adults who have received more than 14 and who have had more than 14 nanomole per milliliter of drug level and less than 14. So it's important to achieve that level. But at the same time, above 20, it may cause a lot of neurological and GI side effects. So really, therapeutic drug monitoring should be done ideally. It is available, I think, in some labs, but it may be very difficult because the drug levels need to be monitored very frequently just to make sure there is no toxicity. So the dose, I'm sure those who have been using it know that it has to be started at 1.5 gram per meter square per day, and that's in 2 to 3 divided doses. And then you keep increasing the dose ideally with therapeutic drug monitoring until you reach the 4 gram per meter square per day dose. But these are just guidances for the dose, because you actually have to titrate it according to the TDM. But I guess, if we are absolutely unable to get drug levels, we could just go by the dose of the drug and watch for toxicity. But it is said that the side effects just come just like that. So the drug levels may just come up in a couple of days. So 2 days ago, the child may not have had side effects, and 2 days later, he may actually present with serious neurological side effects. So it's actually a very dangerous drug to give just like that. So I don't know what the answer to your question is actually, Pankaj. But probably as a compromise, we could going by the prescribed dose and then looking for toxicities. Pankaj?
Am I audible?
Yeah, I think you were muted. Yeah.
So anybody else has any inputs regarding the mitotin use and the dosing? Dr. Amos?
I think Maya had a great sharing there. I mean, these conditions that you share about drug access and access to therapeutic levels, I mean, are really local conditions that only you understand, you know, and working around those there. So I really applaud your efforts, Maya, for, you know, working around these circumstances and still trying to give the best care to your patients through that.
Okay, so can you
I think Pankaj has got frozen.
We might have lost.
Ma'am, it may be a network glitch. That's why his video and audio both got stuck.
Both got stuck. Yeah. And he's sharing the slides. Is he sharing the slides? Because those have also got stuck, I think.
Slides. Oh, okay. Now I think he has disconnected. I hope he will be joining soon.
So you can't see him now. Dr. Sajid, I think we can start with your presentation. Any questions you ask?
Monica, your audio is very low, actually.
Am I audible now?
Yeah, this is better.
So I think Dr. Pankaj has lost his connection. He might join in some time. Dr. Sajid, can you please start with your presentation? We'll take questions at the end for the ACC.
Sure. Can I share the screen? Yeah, I'm already shared.
Sure, sir.
So I'll be very quick in my presentation and will be only relevant as far as the surgical thing is concerned. Though it is a very small presentation, there are so many things to talk about in thyroid gland tumor in children, but I will just keep on business. So we know this is a rare tumor in children and adolescents. It is different both biologically as compared to the adults, in the sense that they have an aggressive presentation as compared to adults. They have extensive lymph node disease, they are metastatic, but at the same time, the long-term outcomes are excellent, even with the presence of so much advanced disease. The flip side.
Sorry to interrupt, we can't see your slides yet.
Is it? I can see here.
It says you started screen sharing, but it's just going round and round.
Are you seeing it now?
No, sir. Can you stop share and then reshare?
Okay, stop share and sharing again. Are you able to see now?
Yes, sir. I hope it is visible to all.
Should I go ahead?
Yes, sir. Yes, sir.
Okay. Okay, right. So I've said about this thing, clinico-biological difference between pediatric and adults, and the flip side that the treatment is not standardized. There is still debate about removal of the complete gland, or even a hemithyroidectomy is enough. Prospective studies are difficult to perform, and as a result, we are guided by retrospective data or extrapolation from the adult world. This is the common presentation of a thyroid gland tumor in children. In addition to the primary, we have found that there is good amount of clinical nodal disease in these children, to the extent that our data almost 70 to 80% of the children had lymph node disease at presentation, which can be really extensive. The workup is very simple. No high investigation are required. A simple ultrasonography is the first investigation we do in children with a goiter. This ultrasound helps us to identify the different characteristic which I have enlisted. And we now also have the TIRAD system, which is very popular in the adult world. It can also be utilized in children. In addition to the nodules, we can also assess the lymph node, and we can also go for targeted FNAC of a suspicious lesion in a diffusely enlarged or a multinodular goiter. So ultrasound is the very simple and most important investigation. Once you have this, once you have identified a target, remember it has to be a target which needs to be FNAC. It cannot be just diffusely, homogeneously enlarged gland and you poke the needle anywhere and you'll get a diagnosis. No, there has to be a lesion which should be targetable. And with very good ultrasonologists, even lesions which are less than 1 centimeter also can be FNAC'd by image guidance. So FNAC is the simplest investigation. It is very reliable. In children, though you may require general anesthesia, in the adult, it is done without anesthesia and it is really well tolerated. And the FNAC results are also now standardized. We have the Bethesda classification, which gives you the different level, the Bethesda 1, 2, 3, and 4. The higher the Bethesda, the more chances, or certainly it is a malignant lesion. And this can also help in keeping the patients on regular follow-up. If you have Bethesda 1 or 2 and radiology is not very convincing, it is thyroids 1 or 2, those are the children who can be subjected for observation. So presence of these radiological and pathological criteria have really helped in coming to a conclusion what should be the next, either observation or surgery. Remember, we are still in the stage of diagnosis. We haven't diagnosed a differentiated thyroid cancer or a thyroid cancer. And so the basic workup, simple to indispensable investigation, the ultrasound and the FNAC. The other diagnostic workup, serum calcium, more of for the surgical planning, just to identify a pre-existing hypocalcemia. Vocal cord, more of to assess the mobility of the recurrent laryngeal nerve before we go in for surgery. Chest X-ray is basically for the anesthetist. We don't get wiser if it is a thyroid malignancy by doing an X-ray. And definitely X-ray, which in our residency days was advised to tell all the examiners an X-ray in AP and lateral to identify Samuma body's calcification. It is of historical significance only. And CT neck and thorax, which is not commonly done. We don't do CT neck and thorax in children or in thyroid gland tumor to describe the primary or the nodal disease, or to find out pulmonary mets at the outset. There is specific indication where we do a CT scan. It was said that for the CT scan, you use iodinated contrast, and this may have an effect on the imaging, the further radioiodine imaging or therapy. But in present day, good ionic contrasts are available, and that is totally taken care of. But having said that, CT scan should not be rampantly prescribed for all thyroid malignancy in children. And rarely, an additional investigation is a bronchoscopy, where you suspect there is tracheal infiltration. This will help us to identify or confirm tracheal infiltration, and if at all, the tracheal inlet is too narrow, this may also give us a pathway to either debulk or laserize the lesion to secure the airway. But these are only special situation when on clinical and radiological thing you suspect there is infiltration or invasion of the trachea. This is an example of where CT scan is required. Large disease, see the airway, it is just a chink. This CT scan is to assess the airway. Extensive nodal disease, where there is a lot of nodal disease, there is one that is another indication. Retrosternal extension or presence of mediastinal disease, that's the indication of a CT scan. And as you can see here, extensive nodal disease, we just need to map out the nodal disease, whether it is confined to the neck only or it is going into the mediastinum. So these are some of the indication of getting a CT thorax. This is not intentional. This was a situation where we did the CT scan to assess the airway and the primary, and incidentally, we found pulmonary metastasis. But we don't make efforts to identify the pulmonary metastasis at presentation because it does not help you in any way. The treatment still remain the same, which is surgery, irrespective of presence of metastatic disease or not. But having said that, if you have done it, it is no crime that if you have seen the thorax to be having metastasis. Now, the big question, hemithyroidectomy and the other so-called near total, subtotal, enucleation and all those things. There are only two surgery in thyroid as far as malignancy is concerned. Either it is a hemithyroidectomy or a total thyroidectomy. Now, what you'll do for children, that is still debatable. We don't have the right answer. In presence of multicentric disease or diffuse enlargement, diffuse involvement of the thyroid, the treatment decision is very clear. Hemithyroidectomy, I don't have any specific data or evidence to say that if the lesion of this particular size is there, you can do away with a hemithyroidectomy. We have done hemithyroidectomy, but those are for special situation wherein we got a Bethesda 4, a benign or not a benign, a follicular neoplasm is on the FNAC. The clinical suspicion is very high, but we don't have enough evidence to knock out someone's thyroid. Only in that situation we have undertaken hemithyroidectomy. Now, you can ask that, do a hemithyroidectomy subjected to frozen section, and then if it is a malignancy, do a completion thyroidectomy. It is very difficult many a times for the pathologist to say that this is indeed a PAPCA. And definitely, if you're looking for a follicular carcinoma, frozen section is not the investigation to be done to identify capsular invasion, which is usually seen on paraffin blocks, not on frozen section. But in children, the commonest malignancy is PAPCA. So in very special situation, very experienced pathologist may help us to say that, yes, indeed, this is a PAPCA, and you can go ahead with a completion or decide to stay with the hemithyroidectomy, this situation. Enucleation, definitely obsolete now and not used. The lymph nodes. Now, this is a very tricky situation. The decision to deal with the lymph node should be available before you go in. It is not a decision which is taken at the time of surgery that I will do lymph node dissection once I open. No, that's not the case. You do an ultrasound. Ultrasound is good enough to let you know that there are lateral compartment lymph node. Or even now, with good ultrasonologists, you can identify central compartment lymph node. If you have these lymph node and if they are FNACable, then you can go ahead with FNAC, have a diagnosis, and then deal with it. If you haven't done an FNAC and you have enlarged node, in that situation, central compartment lymph node inspection or resection, that is a call which has to be taken. But the decision to do the lymph node surgery has to be done prior to the surgery. Lateral node, if there are no lateral node on ultrasound, there is no need of a prophylactic lateral lymph node dissection. For large lymph nodes, or when you find at the time of surgery that there is an extra thyroid extension, in that situation, you can go ahead with identification, inspection, excision of the central compartment lymph node. Now, you can go ahead and say that I will subject the central compartment lymph node to frozen section and then decide on that. That is, it can be done, but usually it can be taken, a decision can be taken that you are okay with just clearance, just inspection of the central compartment lymph node. A clue or tip for the lymph node metastasis is, for some reason, the metastatic lymph node in PAP-C are pigmented. They are darkish. So that is a clue that these are positive lymph node. Even the lateral compartment lymph node, if they are darkish, like charcoal type, then definitely those are this is my observation. I don't know whether there is evidence to sustain that pigmented node is equal to metastasis. But my observation is that if you have pigmented node, those are usually metastatic. When you have a central compartment lymph node detected at the time of surgery in view of extrathyroid extension, in that situation, you can do an inspection of the lateral compartment. Now, these are only situations where you have done inspection, but the decision whether you're going to do or not has to be taken before surgery on your ultrasound examination. This is some of the example. The recurrent laryngeal nerve on both sides are visible. Many surgeons feel that we should not be seeing the recurrent nerve because the parathyroids are there, the vascularity of the parathyroid, the paresis or a loss of function of recurrent laryngeal nerve is there, will be there. Now, these are all unfounded, and you have to have a good clearance whenever you're going ahead with surgery, with all due care, same thing, the recurrent laryngeal nerve in a different position. Here, the central compartment area is there. I hope you're seeing my cursor. That's the central compartment area where nodal disease was there, which was cleared. And that's the thymus. That's not a node which is jutting. The cervical lymph node were also involved. There's a gauze placed here. Lateral neck node dissection has been done. Now, other situation, this is a frank extrathyroid extension. You see, there is the recurrent laryngeal nerve. This is the foot end, and this is the head end. The recurrent laryngeal nerve is going through this extrathyroid extension disease. Carefully, it can be dissected off. There is no need of sacrificing the nerve. Even if you leave some disease on the recurrent laryngeal nerve, that is fine. Saving the recurrent laryngeal nerve is very important because you have radioiodine therapy to take care of the small disease which you left. But whenever possible, not possible, it has to be the recurrent laryngeal nerve has to be saved. Rare situation, it may be impossible, or it may just happen during the dissection. The nerve is teared or tethered or sacrificed. But usually it is possible, irrespective of the amount of extrathyroid extension. The nerve, this recurrent laryngeal nerve, is a very sturdy structure. Don't go by the size. This is a very sturdy structure. You can dissect in the perineurium of this nerve, and you can separate the extrathyroid disease which is there. We have separated this extrathyroid disease. The thyroid tumor is up. There was dense tracheal adhesions also. I would not say infiltration, adhesion, which we were able to dissect it off. And this is a common vessel at near the terminal part of the nerve. You just have to take due care that this is tackled appropriately. This causes bleeding, and this is the commonest site where after a painstaking surgery, you lose the nerve at the upper end. So special care has to be taken, and these all residual disease which are there, this can be excised. That's the recurrent laryngeal nerve, and that blob of what you're seeing is the central compartment lymph node, which has been picked up by a Babcock. Identify the nerve, go into the groove, dissect the nodal packet from here, and after the dissection, you will have a picture like this. If you put your finger here, you should be able to feel the pulsation of the subclavian artery. That's how we say we have done a central compartment clearance. This is the trachea, that's the esophagus, that's the thymus, that's the recurrent laryngeal nerve. Another view of the same thing. Now, these are very delicate surgery, and you should be, it's I should not say that people who have done only should do it. Definitely, you take some person who have done. I'm not saying that you should not do it. Everyone can do, everyone should do it. But remember, this is a very delicate thing. And if you have someone who is done more surgery, definitely please take his help and you can have a safe surgery. The two most important things concerning surgery are the parathyroid and the recurrent laryngeal nerve. As I said, recurrent laryngeal nerve can be saved. It's a very sturdy structure. Even in presence of extrathyroid disease, you can dissect of the nerve. If required, you can take the perineurium. The parathyroid is a little tricky area. Now, in presence of extrathyroid disease, which I showed you, it is really impossible to identify the parathyroid. There are high chances of losing the parathyroid in presence of gross extrathyroid disease, which we see very often. But in absence of extrathyroid disease, it is usually possible to identify the parathyroid. There are several ways of identifying the parathyroid, the rose sign, etc., etc. So many things are there, but most importantly is a meticulous dissection which is required to save the parathyroid. IJV is a very expendable thing. I don't blink also if there is a need for sacrificing the IJV. Another important consequence of handling of bilateral recurrent laryngeal nerve, or even sometime not handling that much also, is a situation wherein you are not able to extubate the child. Either there is tracheomalacia or there is paresis of the recurrent laryngeal nerve because of the paramedian situation. You should not jump in for a tracheostomy. You can keep the continue the intubation for one more day. You can even consider giving steroid, give a trial extubation. Only if it is not possible to extubate, those are the situation where a temporary tracheostomy is required. Rarely is the re-exploration because of slippage of vessel is encountered nowadays, but it may occur. And even rarely in presence of extensive extrathyroid disease, there may be an injury to the pharyngeal plexus. In that situation, you may get children with swallowing difficulty. It usually subsides. You just need to place a Riles tube so that feeding is taken care of by, and as and when the swallowing improves, the Riles tube can be removed. Usually on the left side, we have an issue of the thoracic duct, which is sometime it is injured if one is not careful, especially in presence of extensive disease. So these are preventable complication, but very important thing you have to remember, especially the tracheostomy. You may be wondering that I have done the best of the surgery and why this is happening. This may happen and you should not be afraid of this thing. Just manage it well. Now, there are different histological type in children. The commonest is the DTC, which is the differentiated thyroid cancer. The PAPCA and the different variant of PAPCA are very common. Follicular cancer in children is very, very rare. In our data, we had just one patient of more than 100 patients who had a follicular carcinoma. This is very rare in children. You get a diagnosis, please reconfirm it. The other common tumor in children is the medullary thyroid cancer. Anaplastic carcinoma is also seen. Sometimes we have seen that. And there are rare variants like Ewing sarcoma of thyroid and so on and so forth. But we stick to the differentiated thyroid cancer, and the PAPCA is, with all its variants, are the common. The bad PAPCA include the tall cell, insular cell, Hertel cell. Those are the ones which are the bad performers. We should be careful about them. This is an example of the multicentricity. Tumor is present in both the lobe. And as far as the prognostic factors are concerned, these were the factors which we identified were of prognostic implication. Clinically and radiologically, enlarged lymph node were always positive on biopsy or on excision. And when you have positive lateral node, there is usually a positive central node. So these are the findings from our data. The incidence of nodal metastasis were dependent on these prognostic factors. ETE, so in presence of ETE, extrathyroid extension, there is a role for inspection or exploration or removal of at least the central compartment lymph node. Pulmonary metastasis, these were the prognostic factors. And this is something which is presence defined as presence of radioiodine uptake on the first scan. As I said, we don't make efforts to identify the pulmonary metastasis at presentation because we are not concerned about it. That doesn't make a difference. The addressal to the primary is the important thing. Now, something about radioiodine. No, usually we don't know, many of us don't know what is radioiodine scan or radioiodine therapy. Radioiodine scan is something which identifies residual or metastatic disease after the surgery. So once you do the surgery, the treatment of thyroid is over. No, the treatment of thyroid has just begun. So you cannot be sending a total of मैंने operation कर दिया सब ठीक हो जाएगा, the filmy dialogue. No, you should not be doing that. You should decide whether there is a need for a radioactive iodine scan. And if there is a need, based on the finding, you decide whether there is a need for radioiodine therapy. There is a difference in dosage for the low dose scan, which is the diagnostic scan, and there is a difference in dosage of the therapeutic scan, which is the therapy basically. And it is not that once given, it is done forever. There may be situation that you may not identify the metastatic disease because of too much residual disease in the neck. Once you treat the neck, you do a repeat scan to identify metastasis. If there are metastases, they have to be dealt with. So radioiodine therapy or radioiodine scan can be an ongoing process. It cannot be that given once, done once, it is treatment forever. So that's something very basic about radioiodine. And remember, your treatment of thyroid cancer has started with surgery, not ended with surgery. There is some more things to go. Now, whom to do a radioiodine scan, whom radioiodine scan can be avoided, that's a different thing. I would not like to confuse you with that details. You can definitely read that in many of the textbooks. These are some of the inferences we have drawn from our data. Nodal disease is very common. Whenever the central compartment lymph nodes are there, the lateral compartment may be positive, but when lateral compartment is there, central compartment usually have metastasis. Multifocal disease, extrathyroid extensions are very common, and in presence of them, you have lymph node metastasis. And it is said that if you have lymph node metastasis, definitely you will have pulmonary metastasis. That's not the case, not always. You may have, but you will have is not the case. Lastly, I'll move on to this medullary cancer of thyroid. We have two types, the sporadic, which is rare, and the familial one, which is more common in children because there is an association, syndromic association. Now, this is a situation, medullary thyroid cancer is a situation where the idea of concept of prophylactic thyroidectomy has been described. Prophylactic in the sense it's a normal thyroid, there is no evidence of malignancy, but because of presence of something, you should still go ahead with a thyroidectomy. Now, this is very simple form, but I'm certain that it's very difficult to remember all this thing. So the presence of red codon mutation, especially the number this 883918, if the child with meant to be has these things, there is a high chance of having or developing a medullary CA later in life. And the moment you realize this is there, you should immediately subject the child to surgery in the sense that identified today, subject this child to surgery tomorrow. It's a situation like that. And invariably, you may find that even if malignancy is not there, there is C-cell hyperplasia in these patients. So it is definitely or eventually they are going to develop the medullary CA. So identify and kill the thyroid then and there. So only in those two mutations. The other two mutations, in that you have some breather, you can do the thyroidectomy as early as 5 years of age. You can go ahead with the thyroidectomy. So in short, this is something about medullary thyroid cancer, which is to be dealt with this like this. Anaplastic carcinoma, it's a surgical disease. If you identify it and if it is resectable, you should go ahead with surgery. The other tumors, we have seen LCH also. It's a medical thing. It can be managed medically. Ewing sarcoma, it's a surgical, not a surgical, it's a systemic disease. It has to be managed appropriately. Thank you very much for your kind attention. Monica, to you.
Akriti, you are there. Can you please present your case?
Yes, ma'am.
I've given over the control.
Akriti, you are able to share?
Yes, ma'am.
So you have 1 minute to present.
Okay, ma'am. So good evening, everyone. I'm presenting a case of a 12-year-old male child who presented with swelling in the anterior aspect of neck since 5 months. He had no history of pain, dysphagia, voice change, and no history of any hypo or hypothyroidic features. There was no significant family history in this patient. On examination, we found that there was a diffuse enlargement of the thyroid gland, and there was an ill-defined, painless, firm nodule which was palpable in the right lobe of the gland. There was also a 4 and 2.5 centimeter firm to hard mobile lymph node mass, which was palpable in the right cervical region. On blood investigations, we found that the patient was having subclinical hypothyroidism and the serum calcium levels were normal. We did an ultrasonography for the patient on which we found that the thyroid gland was diffusely enlarged with microcalcification, non-visualization of the normal parenchyma, and increased vascularity. There was diffuse infiltrative lesion which was involving the entire right lobe of the thyroid with a smaller nodule in the left lobe. Multiple enlarged hyperechoic lymph nodes were seen in bilateral cervical region at level 2, 3, and the largest was in the right cervical region at level 4, measuring 2.5 into 9.9 centimeters. During the USG, a fine needle aspiration biopsy was also done from the right lobe of the thyroid gland, where the larger nodule was present, which was suggestive of a thyroid follicular cells which were arranged in clusters and showed focal papillary architecture. The cells also showed nuclear enlargement overlapping with occasional nuclear grooves and rare nuclear pseudo-inclusions. All of these features were consistent with papillary thyroid carcinoma, which was Bethesda grade 6. So our final preoperative diagnosis on this patient was papillary thyroid carcinoma, stage 3, T3N1B M0. The surgical management included a total thyroidectomy with central compartment node dissection and a bilateral lateral neck dissection as the nodes were positive radiologically. In this image, which Sir has already explained, we can see that the thyroid gland has been dissected off the tracheoesophageal groove. The right lobe was bisected as there was extrathyroid extension and it was encasing the right recurrent laryngeal nerve. So in order to preserve and expose the right recurrent laryngeal nerve, we have bisected the tumor to preserve the nerve, and this lesion was removed separately. We can see that the left-sided recurrent laryngeal nerve was also preserved, and this is the tumor bed. Here we can see that the tumor bed is completely free, the right recurrent laryngeal nerve is preserved, and these are the central compartment nodes for which we are beginning the dissection. In the immediate postoperative period, the patient was phonating well, but had some mild hoarseness on post-op day 1, which had recovered by post-op day 4. Next, speech and swallowing physiotherapy was started on post-op day 1 itself, and the drains were removed on post-op day 2. Serum calcium levels were monitored daily for the first 3 post-operative days and were found to be normal. Patient was discharged post-op day 4. On histopathological examination, the gross examination revealed a tumor which was identified in the left lobe of thyroid gland, right lobe, and thyroid isthmus, as we can see over here. The epicenter of the tumor was said to be in the left lobe of the thyroid gland, and the tumor was diffuse and firm in consistency. On microscopic examination, it was papillary thyroid carcinoma of the classical type. It was showing capsular invasion, extrathyroid extension, lymphatic emboli, and vascular emboli. In the central compartment, 5 out of 10 nodes were positive. In the right side lateral neck dissection, 3 out of 12 nodes were positive, and in the left, 6 out of 14 nodes were positive. So our final histopathological staging would be T4A N1B M0. In post-operative period, we started the patient on an iodine-free diet. The thyroid hormone replacement was withheld for 3 weeks, and a radioactive iodine scan was done at 3 weeks, and uptake was seen in the thyroid bed region with thyroglobulin levels at 35 nanograms per ml. Hence, we chose to go ahead with radioactive iodine therapy. Thyroid hormone replacement was with levothyroxine was started and titrated to keep TSH below 0.1 milli international units per liter. We kept the patient on a 3-monthly follow-up. On follow-up, the patient was examined clinically. A USG neck was done, a chest X-ray was done, along with thyroglobulin levels and TFT levels. Thank you.
Thank you, Akriti. You took more than 1 minute.
Sorry, ma'am.
So, no, that's okay. I was just joking. Thank you. Thanks a lot for presenting this case. Dr. Sajid has already answered all my questions, which I had made the presentation for that. And I was about to take questions from the chat box, but I guess that those are also answered. So anyone has any questions would like to can raise hands.
Yes,
Is
Dr.
there any
Monica, I have
question?
one question.
Yeah, please, please.
So it is a role of a lenvatinib in metastatic or a relapsed refractory cases, which is radio resistant. So Sajid sir, something is there? Because one of my ENT surgeon was asking, head and neck surgeon, Abhishek.
Yes, that's a very nice question, Pankaj. And we have situation where it is radio-resistant disease, radioiodine-resistant disease is there. But none of them has progressed and died. Though they have several radioiodine therapy, we haven't progressed to that step. And that was a situation we went ahead with PET scans also in thyroid cancer. But we have patients who have received 10 therapies also of radioiodine, and the disease is still there. Let it be there, and they are survivors. We didn't have any mortality for residual disease. So the role of that thing is in children is not known. We haven't reached that stage. In the sense, our patients, we haven't reached that stage. We have just managed with pulling on. Now, the long-term result of these patients, what are the adverse effect of radioiodine in them, will definitely guide us. Should we keep on doing this thing, or should we just change track? We don't have the answer, especially in our setting. But radioiodine, as we all know, it's not a very simple thing. There are limitation to it, but people have been given, especially radiation medicine center in our hospital, they have quite a big experience with this. They also don't have much to offer as far. I don't know about the adult world whether this thing is done or not.
In adult, they are using a lenvatinib in inoperable cases or something, and there is a good paper. They have shown that this is having a very good response rate before surgery actually. So they are using a new adjuvant sort of thing.
New adjuvant, yes. But that data in children is not there.
Yeah.
But if you find something, Pankaj, please share. Maybe we should be trying that.
Right, sir. We'll do that.
Dr.
Hi,
Amos, I would like, please. I wanted to know your.
Could I just chime in on that with Sajid? I thought fantastic presentation as always. The COG data from the late 90s and early 2000s did tell us very clearly that nodal disease in differentiated thyroid carcinoma in children is definitely more prevalent at a higher rate than what we see in adults. And that's a known fact. However, the data did go on to tell us that the outcomes were not commensurate, right? So despite more extensive nodal disease, despite more aggressive pathological features, the outcomes are still, as what you described, really a chronic disease. So I think that's for us to take note.
Monica, you had a question for Amos.
Yes, sorry, Monica, please.
The mic is muted actually. Dr. Monica, your mic is muted.
Amos, I would like to ask you a question regarding the extent of resection for adrenocortical carcinoma. Do you make it a policy that you see the draining lymph node, or if you have a suspicion that this is more than 200-gram tumor, you should go for elective RPLND, or at least clearance of the lymph nodes in the vicinity?
Yeah, so we do not adopt a policy to do a RPLND. based on size. We would go by what is resectable. I think key to that is really just getting good control of the primary. I think too often times we see cases where whether folks think too much or anything, but you know, they get everything right, but then still compromise the primary, and that really just defeats the whole purpose.
Right, right. And one more thing I wanted to ask was, just keep in mind. So I would hesitate to a similar size tumor in neuroblastoma and a similar size adrenocortical carcinoma. I would have different parameters for going ahead with surgery or not. I do not hesitate for considering non-surgical or no surgical intervention in adrenocortical carcinoma, large size, displacing the liver, extensive nodal disease. That's not an area where we can, unlike neuroblastoma, we can do dissection, go in that plane. What's your experience with this?
Yes, I agree with you completely. It is not a friendly tumor at all. And it's one of those situations where you either have it all lined up on your side, or you know you have to go extra aggressive with the disease. I mean, sometimes, unfortunately, I do understand that different people's practice settings may or may not have access to suitable adjuvant therapies, right? So I appreciate that some of our colleagues on the call may not have the luxury to say, I don't wish to operate. It's a very difficult situation in that setting. Do you opt to attempt the surgery and then have a rupture and set the patient up for local relapse, or a high, a great morbidity with the surgery? Or do you opt to back out, right, and not do anything? I think it's a very difficult situation. But certainly, I think the spirit of what again, the early US literature through the ARAR 0332 protocols did tell us where this is a tumor that you have everything on your side and you go for it, or you don't take chances with it. Yeah.
Right. I recollected my question. The surgery for recurrent tumor, you showed a tumor which had recurred twice and it's in the loco-regional area. But is it always, because we have found recurrences like those are an abdominal disease. You have deposits here, there, everywhere. So what is the relapse surgery experience of yours?
Yeah, well, I think in the case that I shared, it was really the patient's, good fortune to have a lineup where the recurrences were all in the local bed. There was, of course, a clear rupture at the first attempt, the very first primary index surgery, which set up everything up to that. But I think that case is worth using to illustrate also the selection process, because if we had a patient like what was presented where there's metastasis to the lungs, we know that this is distant site disease. This is very significantly less prognosis for the patient compared to what our case that we shared. Likewise, if this is disseminated disease throughout the abdomen, again, the likelihood of gaining long-term and definitive control becomes much, much less. And so, while I presented a case where we did salvage after a second recurrence, I think it's also in a very select circumstances that we could possibly do that.
Right.
Yeah, but thanks for pointing that out. I think it's relevant for us to go away with the correct message.
Right, right. Pankaj, you should take over now.
So actually, I can understand the time is actually too much. It is now 8:50 Indian times. So, but we have one short discussion. So we might skip that panel, but we can ask actually the presenter to present his case. Dhruti, can you present your case, and then Dr. Maya can give the overview on that. And if somebody has a few questions on that, then we can discuss those questions. So I have the presentation for Dr. Dhruti Pandya. So if you can see the, I will share my slide as well. Just a minute. Can you see the slides? So can you see the slide?
Yes, sir. Slide.
Okay. So, Dr. Dhruti Pandya, she's a fellow in pediatric hemato-oncology at St. John's, Bangalore, and she's going to present the two short case on inflammatory myofibroblastic tumor. And then Dr. Maya can give a little bit of overview. We know that these are the very rare tumors, so we must have some ideas while we are dealing with these tumors, and to have some idea about the management of this rare tumors. So over to Dr. Dhruti.
Good evening, everyone. Thank you for giving this opportunity to present two cases in this esteemed meeting. I would start with the case. So I'm from St. John's, Bangalore. The first case is a 12-year-old male child, and the timeline of events goes as he was first presented to us in 2018. He had a history of this type of lesions in his right gluteal area, which was managed at a local center whose histopathology showed that it is some sort of benign fibroblastic bar myofibroblastic lesion. The lesion reappeared in 2020 when it became lobulated. This time, the child underwent wide local excision of the mass, and the biopsy again showed that it is some sort of benign fibromatosis. 2 years later, in 2022, the lesion reappeared and this time started causing some urinary symptoms, which was noted to be in the form of upstream hydronephrosis. So he had undergone a right ureterostomy with PC in situ, and the cancer center started him on an anti-VEGF agent called pazopanib, planned to reassess the lesion after 6 months. But when 6 months later, when the child came to us, in July of 2023, there was no significant change in the mass of the gluteal area, and hence he was evaluated by the pediatric surgery team at St. John's Medical College, where the CCT was done, which is again showing no significant difference in the lesion as compared to the previous time. And now it was also involving the urinary bladder as well as sacrum. So the surgeons did a full thickness core needle biopsy for the diagnosis of histopathology, and at the same time did a urinary management by ureterostomy. Then a multidisciplinary meet discussion was held between us and surgeons and pathologists, and the histopathology was showing proliferating bland spindle cells with chronic inflammatory infiltrate. Considering local aggressive nature of the tumor, we decided to consider it as a possibility of IMFT, initiated him on indomethacin and hydroxyurea. Currently, he's on regular follow-up. Clinical evaluation in the recent times shows that there is decline in the there is improvement in the consistency of the tumor, and the child is on regular follow-up. Second case is a 6-year-old female child who had complained of on and off abdominal pains over a period of 2 months. When was evaluated by her pediatrician, when USG showed a very large left suprarenal mass, and CECT abdomen also showed a huge mass arising somewhere in the left adrenal gland and showing in local infiltrations. So they did a biopsy at a tertiary healthcare center, which showed possibility of spindle cell sarcoma with a Ki67 of 20%. Parents chose to start chemotherapy at the local cancer center, and she was given 6 cycles of 5-phosphomide doxorubicin as per the NRSTS treatment protocol. But after interim assessment, there was no improvement in the size of the lesion. Rather, the lesion had increased and become trilobated in appearance. So the child was referred to us in our surgery department, where the CECT, as you can see, shows a trilobed lesion with a lot of local aggressive nature. The surgeons decided to go in and do the excision, but there was very much a neurovascular involvement, and so they were only able to do gross residue was left post surgery, and a biopsy of the lesion was done. The biopsy images are in the following slide, where the oval to spindle shaped cells were seen with moderate cytoplasm and indistinct cell borders, and IHC in the following slide showed CD99, SMA, Vimentin, and Desmin positive, and ALK positive positivity in the majority of the tumor cells. So the child is currently started on an oral ALK inhibitor, crizotinib, from 2024 February. 6 months later, a USG abdomen is done, which shows a significant interval reduction. So the child is continued on the same chemotherapy as of now with 3 monthly follow-up. Thank you.
So thank you, actually, Dhruti, for presenting the case. And I have your presentation to share with all. So comment on these two cases from Maya, Sajid sir, and Dr. Amos. Any comment you want to add? And I will ask Dr. Maya to give the overview about the IMFT.
Yeah, maybe I'll start with some general comments in the surgical approach for inflammatory myofibroblastic tumor. I think in these cases, we've seen sort of very honest attempts to try and clear this disease. One unfortunate thing is that histologically, these lesions, like desmoid fibromatosis, tend to have very indistinct margins and very indistinct borders. Histologically, the presence of satellite or skip lesions can also be found, which means that just because we see a histologically microscopically negative margin on a single section, it does not guarantee with high confidence that there isn't disease beyond that point, which explains why we can see, for example, in the first case, the histological read was negative margins, but patients still had recurrent disease thereafter. And so we know that this is a phenomenon with IMT. The choice to identify ALK variants in this case, at least through IHC, or to estimate that through IHC, is the right thing to do. I think in present day management of inflammatory myofibroblastic tumors, trying to find an option within your resource to test for ALK mutations is something that is highly valuable. Crizotinib has become a very available drug, especially in adult circles. And I think for us, taking care of patients, at least in major centers, should be able to get access to ALK inhibitors in some form or other. This also has progressed. I noticed the last patient received crizotinib. So a good mention is that even within this space, there is evidence of improved response with other agents like lorlatinib, but maybe let's let Maya chime in on that instead. Well, those are my comments. Maybe we can hear from the others.
Sajid sir, do you have some comments on this?
Maya?
Yeah. So I think in the first case, we probably should tend more towards a diagnosis of desmoid fibromatosis rather than an IMFT. I'm sure that on histology, it's easy to confuse the two. But the clinical presentation of having it in the gluteal/thigh region and such a large lesion is very likely to be a gluteal a fibromatosis clinically. And also the IHC features of beta-catenin positive and SMA were probably also pointing towards it. So that is one suggestion I had, especially since the child has been treated with anti-inflammatory agents and steroids, I think. Maybe we could try giving the child a trial of chemotherapy with vinblastine and methotrexate, which could be used, or we could give a tyrosine kinase inhibitor like sorafenib. That was my suggestion on the first case, but no real suggestion on the second case.
Okay, so Maya, can you give the overview so that
yes.
What we have to do, how do we stage, and what imaging is?
Who operated Pankaj the second one? Where was it operated?
I don't know. Dr. Dhruti can tell, because these are all two cases from Bangalore.
Okay.
Sir, the second case was operated at a local at a cancer center in North Karnataka.
Okay.
Yeah, name I'm not sure of.
Okay. Right. No, I was just wondering if we have done. I don't recollect a case like that before. Okay, no problem.
The Karnataka, yeah.
Oh, okay. Yeah, Maya, go ahead. Sorry.
Pankaj, could you stop sharing?
Yes. Done?
No, I think it's still being shared.
You share it. I think it has been done. There is no sharing. No? Is it still coming?
Yeah, it's still coming.
Okay. Let's see. Now it is coming?
Yeah, it's still coming. You can click on that. There must be a red button which says
Stop
stop
sharing.
share. Yeah. Now
it is
it's
done?
yeah.
Okay.
Yeah, it's done now.
Yes.
So hello again, everyone, and thank you, Dhruti. That was a really very good presentation. You did it in such a short time, and it was very good. So very, very brief overview of inflammatory myofibroblastic tumor. So there are so many tumors which actually can lead to confusion. I think maybe it would be good to have a pathologist like Dr. Mukta also just talk about it once, because there are many such tumors which we often confuse with each other. It's quite easy to confuse a fibromatosis with fibrosarcoma. I mean, an adult type fibromatosis with an infantile fibromatosis and an IMFT and a fibrosarcoma. All of this, I think, could just get confused greatly. So that would also be a good talk to have. So from the clinical point of view, IMFTs or IMTs are quite rare tumors, and they are considered to have an intermediate malignant potential. As Dhruti mentioned, they have risk of local recurrence, which is why I think the first case it was considered to be an IMFT to start with. But they have very low metastatic potential. It's almost, it hardly ever occurs that a child presents with an IMFT, with a metastasis anywhere. So the most common sites are abdominal, mainly in the retroperitoneal area, and the thoracic region, mainly in the lung. But they may also occur in other sites, like the head and neck region, which could be in the orbit. That's a site. They may occur rarely in the central nervous system. I'm sorry, one of the common abdominal sites is also bladder. It's very rare to have IMFT in the limbs. It's usually a painless mass, and sometimes these painless masses enlarge very slowly and gradually until they actually become quite large and then cause symptoms. So they sometimes, especially in our centers, they actually present quite late. And a few of them could have signs of inflammation like fever, weight loss, and malaise. On radiology, I think there was some very good scans in the previous presentation. They are usually solitary masses and generally circumscribed and nodular, but there could be multinodular lesions as well. And the radiological features are quite non-specific. They are usually considered to be malignancies initially until the biopsy is done. And the radiological features generally depend on the site of the lesion. So on the histopathology, we heard earlier. So there are two aspects to this. So there can be there will be mesenchymal spindle cell proliferation, and I think the arrow is not very good, and that's the black one here. It's a spindle cell here, and then there are this is the spindle cell here, the red one, and then there are also inflammatory infiltrates. So that is a reason for this name. So it has both inflammatory infiltrates as well as mesenchymal spindle cell proliferation, and the IHC also goes hand in hand with this. So the mesenchymal markers of Vimentin, SMA, muscle-specific actin, Desmin, all of these could be positive. And there could also be epithelial markers like cytokeratin, AE1 and AE3, etc. So what's really very important and clinically very important, we discussed just in the previous case, is that ALK translocation is seen in a large proportion of these cases. Depending on the case series or the way in which the testing was done, it could be between 50 to 75% of cases. And the ALK translocation could be with a variety of multiple translocation partners. There are also other translocations like ROS1. ROS1 actually acts along the same pathway. It's downstream from ALK, the pathogenesis. So the treatment part would be very similar. There can also be PDGFR beta, RET, and now there's increasingly it's known that there could be NTRK fusions as well in IMFT. Very important from the therapeutic point of view. I think We just heard from Amos about and Dr. Sajid about how complete surgical excision is very important for localized tumors. We can probably hear some more about it later. But if there are a lot of patients who are not operable upfront, and in those cases, we could really consider giving neoadjuvant chemotherapy. So we could give chemotherapy with vinblastine and methotrexate, or in some cases we could give doxorubin-based chemotherapy, although it's more toxic. We've been using it quite frequently because it's a very ineffective and a relatively low toxicity profile of this chemotherapy, which we have been giving, and we've found good responses also. There can be anti-inflammatory drugs which have been conventionally used because of the background, which is very inflammatory. And now there's more and more evidence which is promoting the use of targeted treatment. So what we do not really know is that if there is an incompletely resected tumor, whether there's a role for adjuvant chemotherapy or any other therapy, and whether there's a role for any radiation, probably not, but whether there's a role for radiation is something that's unknown. But what's really pretty, I think, uniformly known is that the outcomes are really good because they're of low malignant potential. It's quite difficult sometimes to get local control, but really there's no danger to life in most cases. So what are these targeted therapies which are used? The first one that was used was crizotinib, which is a first generation ALK inhibitor, followed by ceritinib, which is second generation, and lorlatinib, I think, is third. All three of them have been found to be effective. And although there is increasing evidence that there are NTRK fusions in some children with IMFTs, NTRK inhibitors like entrectinib have not been found to be useful so far. Crizotinib was first tested in a COG phase 1-2 trial, which actually was a very important publication in pediatric oncology. And it was tested in children with metastatic or inoperable ALK positive IMFTs, and this is the dose. And it was found that 86% of patients had some form of response, which was found to be very encouraging. So 36%, in fact, even had a CR. That was an amazing response, actually. And note that these patients were either metastatic or inoperable to start with. And subsequently, there have been case reports. And if you see at the bottom, some of them actually have not had surgery at all. So with crizotinib alone, they have achieved CR. This is from another series. So it is possible to achieve a CR with crizotinib alone. So this is a picture of this very, very large retroperitoneal mass, which has really shrunk after giving ceritinib. This is from the same series which I just showed earlier. And ceritinib, again, here, ceritinib was given 3 months later, this tumor has really shrunk, and that could be excised. And these are all just case reports and case series. But now the question, very important question, is how long do we give it? Especially if we are giving it as a single agent. So how long do we give it as a single agent? And actually, is there a role of giving it single agent? If you give a targeted treatment like this, is it going to cause resistance? There is some evidence in the case of crizotinib that it may actually cause resistance if you give only crizotinib and don't do surgery. So, and whether there is a benefit in the absence of surgery, there is actually in selected cases, there is some benefit in the absence of surgery. So, I mean, really, I think eventually probably what we would recommend would be to, in operable cases, to do surgery upfront, but in inoperable cases, to give neoadjuvant, both chemotherapy and ALK inhibitors, both work well. I think in our context, it's important to know the cost. The cost is substantial. So a month of crizotinib treatment would cost around 80,000 per month. Chemotherapy would be much less. So that, I think, is something to bear in mind. But on crizotinib or ceritinib, the child and the family can go back home. So that is a definite advantage. So there is another tumor which is closely related to IMFT, which is known as epithelioid inflammatory myofibroblastic sarcoma. This is actually an aggressive tumor as opposed to IMFT. And this has also got an ALK gene fusion. I've actually never seen a case. So if anyone has seen a case of this, it's reported a lot in literature, but I've never seen a case. So that is it from me about IMFT. The other thing I wanted to mention is that ALK inhibitors can even be given if ALK is negative and ROS1 is positive. So recently it's been recognized that ROS1 fusions are seen in around 20% of patients with IMFT, and ALK inhibitors will work even in this group of patients because it works on the downstream path. So over to Dr. Sajid and Amos.
So, okay, so I have a few, we will wrap up it quickly, only for few questions. For example, what you prefer to do for a ALK? It is okay to have a IHC positive, you will do the FISH, or you will consider for the NGS to decide whether you are going to use the ALK inhibitor or not. Number one. The second question is like this. You raised that question for how many months or days or years we should use the crizotinib. So that is the second question.
Yeah. So Pankaj, in case of IMFT, you could actually just do FISH. FISH is enough. FISH or actually some people consider that even doing an IHC is enough to in order to give this. Whereas I think what you are talking about is in the case of neuroblastoma. I think that is why you are asking this question, because in neuroblastoma there are some mutations which are actually resistant to crizotinib. And where we actually should do the NGS rather than doing just FISH or IHC. But in IMFT, you could just go with the IHC or even with the IHC, but preferably with FISH or PCR.
Yeah, because ALK has many partners, so it is very difficult to get the special partner, except for one they have quoted in the literature where the even this crizotinib resistance is there. I don't remember the name. So one thing. Another thing is that there is a prospective trial which they compare the chemotherapy with methotrexate and vinblastine, and there is no difference actually in outcome, but the toxicity is less what we use vinblastine and methotrexate for our patient because of the cost. Because you are rightly pointed out that cost is a important part to decide the therapy for these children. So that is there. Any other comment from Dr. Sajid or anyone else? Or if you have some queries, then we can take it and then we can mail it to the respective presenters, and then you can get the your answer.
Right. So neoadjuvant chemotherapy in situation, Pankaj, has really helped. There is some response and the surgeries are okay. But at the same time, having said that, we have IMFT of the urinary bladder and it was like 2 or 3 consecutive cases. There was no response in the sense it remained the same. There was no progression, but the large size, the symptoms, they persisted. But chemotherapy definitely in a situation where it is unresectable or the surgery is too morbid, definitely chemotherapy should be tried. And as far as the surgery is concerned, the surgery should not be a big deal. It depends on the site where it is. We have got simple IMFT like of the omentum, to IMFT of the urinary bladder, to IMFT of the mediastinum also, where a lobectomy was required, multicentric IMFT of the abdomen, but we were able to resect that. So surgery is dependent on the site what is involved. There are no special clues or tips for surgery for IMFT. It remains the conventional surgery, but definitely having something to offer to aid surgery or in presence of unresectable disease, having the things what we have mentioned, it's of great help.
Sajid, so fantastic. You know, our experience in Singapore is almost exactly like yours as well, with IMFTs in the lung, similarly lobectomy and multicentric ones in the abdomen. In some ways, yes, the neoadjuvant ALK inhibitor does definitely improve the surgery, but in some cases it does not. So in our case with the multicentric abdominal disease, we saw a dramatic response to that, allowing us to resect. Subsequently, that resection gave us clear margins, hard to believe in the context of disseminated disease. And the patient indeed remained in remission after that, but is on a single agent ALK inhibitor. That said, everyone becomes very nervous the moment something new shows up in that abdomen, because it's such extensive disease to begin with. So you could argue that despite all of these things we've thrown at the patient, we're still on tenterhooks at the end of the day. The other case is the other extreme with a localized IMFT in the lung. We thought long and hard about that. And even if we did get a good response with the neoadjuvant ALK inhibitor, because of the proximity to the hilar vessels, the patient would still, or the segmental vessels, the patient would still end up with a lobectomy. And so rather than subject the patient to the cost of the neoadjuvant treatment, we opted to give the patient an upfront lobectomy instead. Because it would, same situation, you end up back at square one at the end of the day. So I think a good multidisciplinary discussion is important to check our logic in the decision making.
Right.
So I think this will end our today's discussion, though there is a promising means molecular therapies are coming in a big way. We have seen last case, if you remember, Sajid sir, we have seen this infantile fibrosarcoma. We have seen how we arrange this larotrectinib and this.
You have to mention that, Pankaj. That was really magical. Pankaj, say something, a few words about that.
So what happened that it's a 6-month-old boy. He was actually a 4 month when he came, or 5 month. So then he has the big mass in the ulnar lesion, and it was inoperable to begin with. We started the RMS. It is an infantile fibrosarcoma. So we treated like BCD. We have used few cycles, but when we did response evaluations, MRI showed a little bit increase. And then our orthopedic surgeon was in a view that yes, you can do the amputation because it is increasing. Yeah. So the parents were very much reluctant. The same time we sent the anti-RK, so it was a fusion positive, and so the buyer's company were ready to give us a free of cost patient assistance program under, and they have given us the larotrectinib. We used after a month. Actually, there is a dramatic response, and we continue for 6 months. And then when we send the Sajid sir, so his comment is the remarkable comment was there, and so there was nothing actually to operate, and we are continuing him. Our idea is to give at least 2 years. Let's see if we can get the regular supply from them or not. So that is it. So it is actually molecular therapies have a promise for us. And with this, I think thanks to my all panelists, Sajid sir, Dr. Amos, Dr. Maya, and the presenters, Dr. Tripti, Dr. Dhriti, Dr. Akriti, and Dr. Monica, who has actually given this whole platform and actually planned all these things. We are planning from last, I think, 3 weeks. And we would like to continue this rare tumor series so that we can actually cover more and more, and we can also share people's personal experience or the institution experience regarding their management. So thanks to all. Over to Dr. Monica.
Is she there?
Thank you, Dr. Amos, Dr. Sajid, and Dr. Maya for giving so much time. Like 2 hours is too much to give for this platform.
2
really,
hours, 15 minutes.
Oh God, yes, thanks a lot to everyone. Last, I would like to take photograph if possible, if everybody can switch on their cameras. And I'll record 2 hours, 15 minutes, if it is possible. Yeah, please, can everybody switch on their camera for 30 seconds?
The numbers are dwindling. Monica,
numbers are going, but please. Yes. Dr. Sarin sir, good evening. Thank you for always motivating. Okay, I'm taking photograph. Thank you everyone for smiling. Yeah, thanks a lot. Thanks.
Thank you very much, Monica. Thank you, everyone. Thanks, Amos.
Thank you.
Thank you. Good night.
Bye.
Thank you.
Bye,
Bye-bye.
everyone. Hi, Shalini.
Hi, Dr. Shalini, ma'am. Thank you. Yeah, bye-bye. Momita, you can close the meeting. Thank you.
Thank you so much, ma'am. And thank you, dear doctors, for sharing such valuable insights.
Hi,
I
Sarin
hope
sir.
you had a seamless experience. And thank you once again for extending us the opportunity to host the session. Looking forward to host you again very soon in another interactive session in the near future. Till then, stay safe and healthy and have a nice day. Good night to all.
Thank you. Hi, Shanur.